So in this video we are going to talk about history taking in physical examination in case of cervical spine pain. So first we'll start with pain. When the patient presents to your clinic, how bad is the pain on a scale of 0 to 10? In case of axial neck pain, patient presents with neck immobility and stiffness and active trigger points in areas like upper trapezius, periscapular area and cervical paraspinal muscles. Second, age. So age is very important. Osteoarthritic signs and symptoms in cervical spine starts after the age of 60 years and older. To be more specific, 85% of the population over the age of 65 years and 60% of the population over the age of 45 years will show some signs and symptoms of spondylitic changes. Third is location. Now, in case of cervical radiculopathy, the dermatomal pain pattern will show or will lead to some identification of the nerve roots involved. Like, for example, if the patient has tingling sensation or pain in the middle finger, will show cervical spine pathology at the level of C6, C7. Now, we'll see the gradings. According to Bone and Joint decade from 2000 to 2010 task force recommended that all the patients with neck pain are divided into 4 stages or 4 grades of severity. Now we'll see the grades. So grade 1 patients, it goes from low to high severity according to the grades. So grade 1, patient has neck pain without interference with activities of daily living or ADL. Grade 2 patients will have neck pain with interference of daily activities. Grade 3, patient has pain with radiculopathy or radicular pain, where the pain radiates down from the neck to the upper extremity. And grade 4, patient presents with major pathology or signs and symptoms with infection and instability. Now we'll see the activity. So usually if the patient presents with upper cervical spine pain, they reproduce the pain symptoms in excessive nodding movements. Now excessive nodding movements where you check in history, where you check if the patient requires a corrective glasses, if the patient has poor posture, forward head posture, or if the patient is a mouth breather has a forward head posture. Now, lower cervical spine or cervicothoracic area pain or pathology, patient presents with increased reproduction of pain in push and pull activities. Push and pull is like heavy activities where patient move the furniture, clean the lawn. And extension movement, lastly, the extension movement will aggravate the radicular pain into the upper extremities. Now, we'll see number 5, onset of pain. Onset of pain from cervical spine. So usually the bone pain occurs immediately, but sprain and strain of muscles and ligaments will reproduce the pain and other symptoms even after several hours or even days later. Now we'll see the number 6 is type and quality of pain. Now, if the patient has cervical radiculopathy, usually the symptoms are unilateral. So unilateral symptoms with altered sensation, muscle weakness, and reflex hypoactivity where DTRs are reduced. Whereas in case of cervical myelopathy, patient has spastic weakness, paresthesia, incoordination, proprioceptive balance deficits, and even sphincter dysfunction where patient has bowel and bladder dysfunction. Now we'll see the number 7, disc, very important. So you ask the patient where the pain can be reproduced with intrathoracic or intra-abdominal pressure increase, where the patient will say, oh yeah, my pain is increased after, like during the coughing, laughing and sneezing activities. Number 8, headache. So is the patient has headache with the cervical pain? C1 pain or first cervical vertebra pain usually presents at the base of the neck and or on top of the skull. And C2 pathology to the second cervical vertebra patient presents with the temporal pain. Now, number 9 is position change. Is there any change in position will reduce or decrease the headache or referred pain into the upper extremity? Or sometimes the patient will tell if I put my affected extremity on top of my head, my pain and headache symptoms will reduce. That is called as a positive Bakody's sign. If the patient has a Bakody's sign positive, patient has pathology at the level of C4 and C5. Now, sometimes bilateral tingling sensation will lead to systemic disorders, will indicate that there can be some problem in systemic disorders, or patient maybe has diabetic, or patient has alcohol abuse. But bilateral symptoms are sometimes indicative of neuropathies or space occupying lesion in the spinal cord. Next, we'll move to the physical examination. So the first and foremost is Spurling's test. Spurling test, in case of cervical radiculopathy, you ask the patient for cervical extension, and ipsilateral side flexion on the cervical spine will reproduce the same pain and signs and symptoms of cervical radiculopathy. That is a positive Spurling's test. Now, according to Shabbat et al. In the year 2011, Spurling test is 95% sensitive and 94% specific. Now, in case of cervical myelopathy, we'll see the Hermitte's sign. Hermitte's sign is when you flex the cervical spine, the electric shock-like sensation in the spinal cord and upper extremities will lead to a positive Hermitte's sign where there is some problem in the dorsal spinal column. Second, that is more specific for the cervical myelopathy, that is Hoffman's sign. Hoffman's sign is snapping movement or a flicking movement of a distal phalanx of a middle finger will reproduce reflexive flexion movement in the thumb and index finger, is positive Hoffman's sign. Third is a Romberg's test. Now, Romberg's test is you ask the patient with the eyes closed. So eyes are closed. Patient produce increased swaying movement. So that indicates cervical myelopathy or problem with the spinal cord. Romberg's test sometimes presents with the positive UMN signs, upper motor neuron signs. It's spasticity, reflexive hyperactivity, sustained clonus, and extensor Babinski response. And last and foremost is a grip and release test, where you ask the patient to make the fist for 20 times in 10 seconds. So there is lack of coordination and patient cannot produce the complete flexion and extension movement of the phalanges. Decreased cutoff value can be seen in grip and release test with increasing age, and even the female gender has decreasing cutoff values compared to male gender. Thank you.